How's it going, guys? Medium difficulty question, pulmonary hematology, step 1, FMIM2CK. A 28-year-old woman, she has mycoplasma pneumonia. This x-ray showing you bilateral interstitial infiltrates. That's actually not so crucial, okay? You look at this, you say, I don't know what I'm actually seeing. Doesn't matter, okay? Because you got an otherwise young, healthy patient who has dry cough with low-grade fever, and OMG, she hikes and rock climbs. This is walking pneumonia. Okay, so walking pneumonia means you got patient who's running around otherwise healthy, but has a bad chest x-ray and has some sort of pulmonary infection going on. This is bilateral, atypical pneumonia, whereas lobar pneumonia is usually strep pneumo. Okay, so mycoplasma pneumonia, the white blood cells should be 4 to 11,000, normal range. You don't have to have leukocytosis. Hemoglobin's low, 9.5, should be 12 to 17.5 menstruating women, 13 to 17.5 non-menstruating women and men. Now, the serum LDH is increased. I'll explain this as we move through the question. If you've been following my content, I've talked about this, so you're rewarded for that. Well, are we really surprised that your scores would go up if you have been doing my content? So what's most likely to be seen in this patient? Should I say decreased MCV? Wrong fucking answer. This is an iron deficiency anemia, okay? So this patient, there's another reason why the hemoglobin's low. But if we had iron deficiency anemia, which of course could be seen in women of menstruating age, extremely common, but there's an obvious reason why it's not IDA in this case. So if you have acute blood loss, let's say you donate blood or there's exsanguination from a trauma or surgery, then MCV would still be normal acutely when you record it. Wrong fucking answer. Choice B, increased lymphocyte percentage. Wrong fucking answer. So, I mean, this is bacterial, so almost always in the setting of bacterial infection, it's going to be increased neutrophilic shift, not lymphocytic shift. I say almost always because you can have times like, let's say, pertussis, which isn't limited to pediatrics. Pertussis causes reactive lymphocytosis. That's an exceedingly high yield point. I don't want to go too off on a discussion about that right now. You can have things in neonates like chlamydial pneumonia following ophthalmia neonatorum, which is neonatal conjunctivitis, where chlamydia is obligate intracellular. And in that setting, I've seen questions where they give you a lymphocytic shift because you need lymphocytes to kill what's inside the cell, whereas neutrophils are humoral immunity, killing what's outside the cell. Wrong fucking answer. Choice C, increased RDW. Wrong fucking answer. So this test, what it means for USMLE is it's highly sensitive for iron deficiency anemia, meaning if RDW is not high, you can say, cool, not IDA. I had talked about in the past how if RDW is high, that means IDA. That would be synonymous with RDW is specific for IDA. There's a question that shows up on one of the new family medicine forms, FM form 4, where it's thalassemia and they give an increased RDW. So there's one question in history where RDW is high in the setting of thalassemia. Thalassemia, it's usually low. Okay, it's low or normal. Low or normal, usually thalassemia. But OMG, there's one question where it's high. So you say, Mike, I don't understand. Can you elaborate? I just fucking said. RDW doesn't equal IDA. It's just if RDW is usually high in the setting of IDA, but if RDW is not high, cool, not IDA. It's sensitive for IDA. Wrong fucking answer. Choice D, osmotic fragility. Wrong fucking answer. For hereditary spherocytosis, spherocytes, right? Autosomal dominant, heterozygous mutation, anchorin spectrin, band proteins. So normocytic, normochromic anemia, you need to know that. There's a question where they ask hypo, normo, hyper, micro, macro, all the different combinations for cytic, and you got to know it's normochromic, normocytic anemia. It's a long discussion. Patients often get calcium bilirubinate, cholelithiasis. So they need a cholecystectomy as well as a splenectomy to definitively treat it in order to remove that ongoing RBC turnover. Wrong fucking answer. Choice C, positive direct antiglobulin test, which is another way the USMLE will write Coombs test, which means we have antibodies against RBCs. Correct answer. Diagnosis is, as I already talked about, mycoplasma pneumonia, but holy shit, you can get cold autoimmune hemolytic anemia, which means cold agglutinins, which mean IgM antibodies against RBCs causing hemolysis. That's why our hemoglobin's low. And as I said, the reason we know it's not IDA due to menses is because we've got increased LDH. RBCs are packed with LDH. And one of the ways the USMLE will denote hemolysis is increased serum LDH. So when we read this stem, we just say, oh, hemoglobin's low and LDH is high. That's obvious hemolysis. Easy. Okay, very easy. Correct answer. You know the deal. I'm to make more content. If you like my stuff, subscribe my channel. Appreciate your time. That's it.